Well, good day to everyone. I'm John Finnegan. I'm Dean of the School of Public Health at the University of Minnesota, and I am glad that you could join us from home during this unprecedented time in our country's history. Today, we're going to have a conversation about public health during COVID-19. And there will be, we believe, more than 960 of you online tuning into this webinar. So we want to welcome each and every one of you. I encourage you to ask questions during this conversation, and I will be watching for them as they come in. So please use the Q&A button located at the bottom of your screen or on your device to submit a question. At the School of Public Health, many of us, and certainly that includes today's panelists, are applying our expertise to understand this new virus and the disease it causes, and to help our state and our world cope with its impact. On your screen are just a few of the areas where we are now putting our attention: modeling the outbreak, testing healthcare workers, and exploring the cumulative stress of social distancing. We're also producing a weekly podcast called Health in All Matters, and this explores the aspects of the pandemic from a variety of different viewpoints. Last Friday, we delved into the strains on the food system with insights from producers to those who rely on food shelves to keep their families fed. And you can access the podcast series from the sph.umn.edu front page and on Apple Podcasts. And by the way, if you are interested in using hashtags today for this webinar experience, you can use two. One is Invisible Guardians, capital I, capital G, Invisible Guardians. And the second one is COVID Convo, COVID, CONVO, all in caps. And we invite you to use those tags. Throughout this time of uncertainty, we're going to be offering events such as this one to explore the issues around this pandemic. And the more that we understand COVID-19 and its fallout, the better we will be able to adapt and prepare and plan for those yet to come. On Sunday, Twin Cities Public Television premiered a documentary that tells a modern story of public health and the challenges it confronts. Our school was fortunate to co-produce the film with TPT in partnership, and it features our panelists today, as well as other faculty members, students, and community partners. The documentary is called Our Invisible Guardians. Public health and the professionals who do its work are often unseen, undervalued, and under-resourced. COVID-19 has changed their visibility dramatically. Whether it changes their value to the country on a long-term basis and increases the resources that they need to do their work, well, that's a key question, the answer to which will shape our future for better or worse. This webinar, with its title No Longer Invisible, Public Health During the COVID-19 Pandemic, is a follow-up to that TPT documentary. Public health is no longer invisible. It is a prominent and critical part of managing this crisis. Public health scientists and professionals are collecting the data. They are analyzing the models that are needed to help craft policies on the state and federal level. And many are also involved in the trials of potential treatment drugs and vaccine development. As the weeks progress, frontline public health workers through the CDC's new community protection teams will scramble to help us get a better handle on infection rates and spread. Our panelists today are deeply involved in the COVID-19 response. They guide how we meet the pandemic's many challenges. Although they will introduce themselves and their work more fully, I want to say a few words about each of them right now. Regents Professor of Public Health Michael Osterholm has always focused on infectious disease contagion, spread, and containment during his entire professional career, which included some 20 years
right?
as Minnesota's state epidemiologist. His 2017 book with Mark Olshaker, Deadliest Enemy, Our War Against Killer Germs, contains a surprisingly prophetic scenario of what we are facing right now with COVID-19. As director of the Center for Infectious Disease Research and Policy at the University of Minnesota, he pushes for policies anchored in science, common sense, and urgency as he influences policymakers to take action. Our panelist, Tim Beebe, is Mayo Professor and head of the Division of Health Policy and Management at our school. Most of his work entails engaging Minnesota's healthcare delivery systems in rapid iterative learning. During this pandemic, he is working with the Minnesota Department of Health to design coronavirus seroprevalence surveys that will test the blood of people not diagnosed with COVID-19 to determine whether they had previously been infected. The goal is to determine how widely coronavirus has spread in communities. Professor Marizen Ramirez is an expert on childhood trauma, disaster preparedness and response, and injury and violence prevention, all elements that are at play during the COVID-19 pandemic. Domestic violence and childhood trauma are particularly worrying as stress mounts within households. As the director of the Midwest Center for Occupational Health and Safety, she is also building teams to study grocery store worker risks and safety. School of Public Health Professor Jeff Bender heads up the Upper Midwest Agricultural Safety and Health Center, known as UMASH, and he is a veterinarian as well as a public health scientist. His COVID-19 work focuses on protecting farmers and farm workers from infection, including migrant and new immigrant workers, and also veterinary medicine professionals who deal with animals from households where someone is ill with the virus. I'm going to start today by asking Mike Osterholm to introduce himself, to tell us about his current focus on COVID-19 and what he is doing to cushion its impact. And by the way, I hope that you were able to read his New York Times commentary this morning on testing. You'll find it very interesting. And all of our panelists will be speaking more in the question and answer session. So after each speaks, they will pass the baton to the next speaker, and we'll keep going around the horn here and come back to answer questions. So please welcome Michael Osterholm.
Thank you, John. Sorry for the delay there. First of all, I thank you for the kind introduction, and I just want to note that when asked today to talk about the work that I do, I have to in the first instance, note that the work really is a collaboration with the group at the Center for Infectious Disease Research and Policy and the team that we have assembled. A number of us have now are together for more than 30 years, having worked together at the Minnesota Department of Health, our collaborative time at the university, as well as at CIDRAP. By way of background, as John noted, pandemics have been something of great interest to us and a concern. I wrote about the lack of preparedness for a pandemic back in 2005 in Foreign Affairs and New England Journal of Medicine. Unfortunately, I wish we were back in 2005 because our preparedness was actually greater back then than it is today, in the sense that we have less reserve, less surge capacity, and we're much more reliant on international supply chains for medical supplies, drugs, etc., than we've ever been in the history of modern medicine. At the same time, as we have talked about what we need to do there, we also have tried to lay out a realistic view of what might happen. As John noted, I wrote a chapter in my 2017 book, Deadliest Enemies, that while I suggested it was a influenza virus that would cause the pandemic from China, it turns out to be a coronavirus. And in that sense, otherwise, the scenario has played out largely just as we laid out in that book. So where are we really at today? Well, first of all, what CIDRAP does is we provide information. We have an extensive activity and news and other information. Just to summarize what's happened over the course of the past several months, we've had over 12 million users on our website from more than 180 countries and territories hitting on the website for everyday updates and news. I'm now doing a weekly podcast for just in the last 2 weeks. There have been over 36,000 views on that. But probably more importantly, I've learned the power of social media and the podcast world in a way that I could never imagine. In early March, I did the Joe Rogan podcast, which today there have been over 36 million downloads and view of that piece on the coronavirus situation. Even more amazing to me was I filmed an hour-long version of the Red Table talk show with Will Smith and his wife, Jada Pinkett Smith, and their family, and discussed the aspects of what was happening here, what we needed to do and understand. And that has now been downloaded 113 million times and viewed. So you can see the power of the media as we know it today and how public health has to outreach is really very, very important. So if I could just summarize where we're at today, and John noted that our group, again, has been working on policies and how to respond. Today, the op-ed I have in the New York Times is really about testing and the challenges we have with testing, which are many. It's not straightforward, and many are based on epidemiologic principles, not just public policy / politics. But I think just to give a sense of where we're at, and this is one of the things that we've been doing, and we'll be publishing more information this week on this, but let me just give you a sense of why I keep saying we're only in the second inning of this 9-inning game. And that is, this virus is acting very much like an influenza virus. Its transmission characteristics are very similar, has a longer incubation period. Surely it has some slight differences in clinical presentation, but on a whole, it's acting like a flu virus. We're planning for what will be like an influenza pandemic. And given the fact that we believe at best 5 to 15% of our country's population has been infected, with 15% being in some of the hot spots, 5% being in much of the country, we know that this virus will continue to keep transmitting with its characteristics of respiratory transmission well into a time when 60 to 70% of the population will need to be immunologically immune to this virus, either through natural infection or through vaccine. Well, vaccine's not coming soon. I'm hopeful for a vaccine, but we know hope is not a strategy. So what that means is we're going to really be dealing with this virus as it seeks out humans and infects them. We're a long ways from the end of this if you think about 5 to 15% currently infected with all the damage it's already wreaked. And you think about what it will take to get to 60 to 70% before herd immunity principles kick in. So what we're trying to help for is plan over the next months, 16, 18, 20 months, how this might look. And I think it is going to end up looking very, very much like a 1918 type pandemic. Let me just close by saying, in terms of what the School of Public Health is all about, is our need is very, very acute. Well, the heroes on the front lines of medical care are absolutely represent the finest hour of medicine and what we do. Public health is adding very important information in terms of how we respond, the policies that we adapt, and what we can do to be most effective to trying to minimize the number of cases until we have that vaccine. And so that's what we will continue to do. And I look forward today to discussing some of those issues and policies with you. With this, I'm going to turn the microphone over to Professor Tim Beebe, who is Mayo Professor and Chair of the the Division of Health Policy and Management. And Tim will discuss the work that they're working on as it relates to this area. Tim, it's all yours.
Thanks, Mike. It's always wonderful and horrible to follow you because you're so interesting. So thank you for handing it over to me. So yeah, I'm Tim Beebe. So I'm not an infectious disease epidemiologist, and I don't really work in this space up until recently. So most of my time, and I talk a bit about this on the documentary, is spent engaging the healthcare delivery system. It's an extension of the work I did during my 12 years at Mayo Clinic, but really kind of blown up to be a statewide thing. Basically, what we're doing is I've run a research and training program that really tries to close the gap between practice and research and allows sharing of ideas, prioritization, and co-creation of knowledge in a manner that aligns with the pace of the practice. And so we pride ourselves on rapid iterative learning. And so we work with a lot of different healthcare delivery systems, and it's a little bit different than what we've been typically doing in the past, where we've really been good at studying the healthcare delivery system. This is really studying in healthcare delivery systems and a lot of embeddedness there. And so one of the challenges this virus has brought to us is one of the bedrock principles of this learning health systems research perspective is setting up a system where evidence informs practice and practice informs evidence. And it's just the pace of change is just an incredible, it hasn't been envisioned by those of us who work in this space. So for example, one of the things that we try to do when we work with healthcare delivery systems, the practice identifies priorities for the system and guides the process that aligns with system operations and the clinical practice. The researcher brings an understanding of the state of scientific knowledge. And so what we try to do before we embark on anything is do these rapid synthesis of the literature and try to stay on top of what the science is saying ought to be done in a particular situation. Again, we've been able to do that in a more rapid way than has historically been done. But here, the things are changing by the hour. We were blown away by these estimates where medical knowledge changes every 73 days. Medical knowledge in this context is changing by the hour. And so to try to do synthesis of the literature to inform how practice ought to operate in this context is really difficult because, as I said, it churns. And talk about a supply chain problem. It's this tension between alacrity and quality, where, as evidence comes out, you want it to be disseminated very quickly. So there are a lot of platforms like medRxiv that post research before peer review. And it says there's a big disclaimer on the website that says media don't cite because it hasn't been peer reviewed. While many of them end up like in JAMA or New England Journal of Medicine, some of the quality is unclear. So what do you do with that? How do you collect that information when there could be pearls as well as some dreck in there? So it's been really a big challenge for us in this context of rapid change to do that. And the last thing I'll say is, again, I'm a survey methodologist, and I've been doing surveys for most of my life. And I've written a few papers, and I wrote a chapter about 10 years ago on the collection of biospecimens and population-based surveys. And I have a section there on collecting biospecimens like urine, saliva, blood in a decentralized way, where we send the packets to the survey respondent, and they draw their own blood or collect their own urine and send it back. But I've never really done it. And now I'm working with the Department of Health and talented colleagues in epidemiology and environmental health to do this population-based survey where we are trying to collect data in biospecimens in a decentralized way, liquid capillary blood, as well as dried blood spots, to see if we can get information from a robust representative sample to get a sense of how many asymptomatic, pre-symptomatic, or clinical cases are out there. Noting that there are still some challenges with the sero testing that Mike referred to into his New York Times piece. So that's kind of what I do and how COVID has impacted my work. And it's been an exciting time. It's made for long days and long nights, but I do have to say, being up close and personal with the healthcare delivery systems, how engaged and how impressive our system is here within the university within Minnesota. And trying to use the best evidence and capturing what they've done so that they can share across systems and breaking down some of those competitive silos to share across the system. So I think, the better angels of their nature have really emerged in this horrible time. So that's it. I do want to introduce my colleague in the School of Public Health, Associate Professor Marizen Ramirez from Environmental Health, to talk about some of her work. So I will log off and hand it over to you, Marizen.
Thank you, Tim. Well, thank you, everyone. Thank you for having me here today. I would like to tell you a little bit about myself and then the work that we're doing in environmental health sciences. I'm a trained injury and violence prevention epidemiologist, but first and foremost, I direct the Midwest Center for Occupational Health and Safety. We're one of 18 centers funded by the National Institute of Occupational Safety and Health to support worker health and safety research, training, and education. We have about 7 academic programs within our center in industrial hygiene, occupational and environmental medicine, nursing, epidemiology, injury prevention, policy, and engineering safety. A wide broad of faculty with this expertise. And what we've done is we've pivoted some of our outreach and research efforts to really address COVID. Obviously, worker safety and health is a priority, and COVID is impacting especially our essential workers out there, and also workers who will now have to work from home and balance that work-life environment. It actually fits within this framework of total worker health. So through our center, and you can see here, we have a webpage in which we are offering resources that have been vetted through with our faculty and through NIOSH, the National Institute of Occupational Safety and Health. We are also advertising webinars that are upcoming. We have archived webinars. In fact, we've got Somali translation of hand washing, a short video on that. We are hosting a webinar on Thursday on aging in the workplace. Next slide, please. At the same time, you know, through the faculty that I work with in our center, I also want to highlight some of the research to practice activities that have focused on, one is on occupational health, and Susan Arnold is working with a team from engineering and medicine. And as we know, there is a real concern about shortages of masks here at the University of Minnesota Hospital. So her team is working really feverishly around the clock to test and evaluate new masks that they have developed real time. And they found that these masks that they're developing provide 50 to 90 times more protection than our standard masks that are used for procedures, like the ones that are used by nurses, folks that draw blood, etc. Now, what they've done, because they found some really promising evidence of effectiveness, is they're scaling up and they're producing about 40,000 masks with the help of volunteers. The second study I wanted to highlight is, sorry, go back, please. Oh, sorry. All right. The second study I want to highlight is one that is being led by an infectious disease epidemiologist, Jillian Tarr. And what Jillian is doing is she is leading, and I'm working with her on a study that's evaluating and studying how households and older adults are complying with social and physical distancing guidelines that are now in place in our state and in place in other states throughout the country. We are working specifically with Minnesota residents, and just last week, real time, we've expanded the study to include Iowa residents to examine how households are complying with social distancing and what kind of contact patterns are implemented. My role as an injury and violence epidemiologist is we've added some specific elements that are addressing stress and also measuring some concerns about domestic violence in households. I've put up here a link to our recruitment because we're still actively recruiting families of households with children less than 18. So we encourage you all to go and spread the word. And we've got about 300 participants in the state of Minnesota and about 90 participants in the state of Iowa. Next slide. So that's the work that some of my faculty and colleagues in environmental health and in our center are engaged in. I'd like to tell you a little bit now about how COVID has really pivoted the work that I am doing, the work that I'm truly passionate about. As I mentioned, I'm an injury and violence prevention epidemiologist, and injuries and violence are a leading cause of death for persons ages 1 to 44. It accounts for more than more potential life loss than heart disease and cancer combined. And it includes various mechanisms like falls, opioids, motor vehicle crashes, suicide, and homicide. So my everyday life is really focused on community-based approaches to preventing violence and its adverse impacts, particularly among children and especially among children of color. So this recent study, it's funded by the National Institutes of Health. It's a project in which we are working closely with schools, about 6 school districts throughout Minnesota, both in the metropolitan as well as greater Minnesota. We are looking at how families of color are impacted by trauma and childhood adversities. And this includes racial microaggressions, bullying. We're teaching staff at school on how they respond to children with trauma and how they can use culturally responsive methods and communication skills, and specifically psychological first aid. So when COVID hit, we were struck by how schools have dramatically changed. As many of you know, we're in a distance learning environment. And ultimately the stressors that families are experiencing, the financial stressors, social isolation, loneliness, reduced access to resources, these are factors that can lead to stress, psychosocial stress, that in turn leads to substance use, alcohol use, problem behaviors, suicidal ideation, and ultimately abuse in the home. So what we have done is we've quickly pivoted our programmatic efforts to address COVID as a type of trauma. And it makes real good sense. In fact, a lot of the work that I began actually started with, work from disasters that have impacted communities. And COVID is a disaster that is impacting our community. We're training our staff on how they can support children during these disasters and providing them real-time resources online. In addition, we have here, I've listed up here some resources, again, that we are sharing with our communities. We've got resources here on domestic violence, as we see that that's a real great concern as calls to domestic violence hotlines are increasing dramatically in countries like France and definitely in our state, we've seen about a 20% increase to calls and about a 25% increase in law enforcement responses to domestic violence. And so as we move forward with this work, it's real-time work. We're pivoting because we as public health researchers, that's our job, is to address the real-time traumas that are affecting our communities. And I'm really excited to be partnering with so many people out there to address the problems that are impacting our families and communities throughout the state and throughout the country. Thank you. So now I'd like to introduce my another esteemed colleague of mine, Dr. Jeff Bender. He's a veterinarian and public health practitioner within environmental health sciences. He directs the Upper Midwest Center for Agricultural Safety and Health. So I'm pleased to now shift over to Jeff as he speaks to us about some of the critical issues that are impacting our farmers in our country.
All right. I want to thank you for this opportunity to talk about some of the work of many, and so I have the privilege of just kind of sharing some of the work from our folks that are working at our center, and then also I'll specifically talk a little bit about the pandemic and how it's affected me and my work. First of all, our center was really dedicated to really serving farmers, farm families, producers, and trying to provide timely, practical, and really relevant work to reduce injuries and risks for many of our rural farmers in the region. That focus really hasn't changed, except for the fact that we can't get out on farms. And actually now we have a lot of concerns about the type of workers and access to workers, and how do we keep those workers safe from a different issue, and that being an infectious disease issue. And then the last thing I just want to take just a few moments on is talk about, how our lives change a little bit and how you get pulled into different focuses, different areas that you never thought that you would be part of as part of that. But first, some of the work that we've been doing is really been getting out to farms, getting out and actually talking to producers, talking to the farm worker and training them. And many of our staff are doing that. And they do that in language specific ways, oftentimes in Spanish, oftentimes with coming out early in the morning, 6 in the morning before they might start milking, and then also after they finish their shift. And so one thing to remind folks is that, especially the immigrant labor workforce, is really what drives a lot of our agriculture throughout the Midwest. I mean, nearly most of our milk, almost 80% of the milk that we produce, is probably from farms that have an immigrant workforce. And so they're a very important part of the livelihood, not only of the farmers, but also for our industry. And so part of what we do is training those workers, making sure that we can kind of prevent injury and illnesses and keeping them as safe as possible, and providing those materials that actually support that. So that's actually what we were doing, up to about 6 weeks ago. And as you can imagine, that dramatically changed. I mean, basically, to maintain social distancing, we're not getting out on farms. But there have been a number of big issues or concerns for producers is how do they maintain a healthy workforce? Oftentimes they think, well, gosh, I'm out in the rural areas, I'm out in the farm areas, I'm already isolated, I don't need to really worry about that. But there's not a lot of workers. There's limited number of workers. So if that one worker becomes ill, it's quite dramatic. And so we've been trying to work with farmers, producers, and thinking about how do we try to keep that workforce safe. And so, up to that point, we might have been dealing with, grain bin safety, but now we're talking about, how do you know if your employee is sick or not? When should they come to work? When should they not be at work? How can they protect themselves? How can they actually practice social distancing on a farm? The other thing too is and we were dealing with this before, is the mental health issues that oftentimes are problematic in our rural communities. Basically with low income, the stresses of farming, those type of things. These are now exacerbated more by the mere fact that we've got another stress onto the farm economy. And so that's another thing that we have been really working hard with, is how do we actually deal with this high stress, this high anxiety? How do you aware of some of those signs of stress? How do you check into your neighbors, or encouraging folks to check into their neighbors? How do we actually encourage, virtual social support systems through local churches or virtual coffee visits? How do we actually continue to create that community of support in that regard? So that's, one of the things that's incredibly important. So that's, one is just that basic reminder message that our rural communities are important, and we need to reach out to them. As part of that, we also been working on national plans. How do we support farm workers across the country? Anything from strawberry picking field or workers to lettuce pickers in California. And so we've been working on just interim guidelines for those workers. How do we protect them when they get in a truck with other people, or they might be working in a harvester? How do we actually deal with, some of the housing situations where they may, have more congregant housing, and supporting in that regard. The last thing I just want to briefly mention as a veterinarian is this disease has affected all aspects of our lives, including our pets. And so one of the things that I was asked to do was to serve as the hospital epidemiologist for our teaching hospital. And the impacts were dramatic. Basically, the services that a veterinarian would provide were restricted to emergency only. There was the new advent of telemedicine. There was the issue of giving away our personal protective equipment to our human healthcare providers. How do we deal with ill clients that have a pet? And how do we also deal with some of the employee occupational concerns that are there? But then also, what about the animal concerns? Can you get this disease from you? And so what things can we do to actually help support some of those issues or areas that come up? And with that, we've had to revise plans. We've had to revise a number of different procedures of how do we incorporate social distancing, how do we actually put in administrative controls and deal with some very hard things like euthanasia, and how do we actually deal with some practical things about face masks and other personal protective equipment. So those are just some of the issues that really have that we've had to deal with, or at least personally I've had to deal with this impact. And so, in closing, just a couple things is just reminding the value of neighbors and checking in on people, and the value of community, and then also just the systemic impact that this disease has, and how we actually need to think about some of those manifestations. And with that, I just have one slide that I would just talk about some of our resources there that as a result of this, that we've actually tried to put together in a timely fashion to deal with some of the kind of important issues that are affecting our rural communities. So with that, I'll turn it back over to you, John.
All right, Jeff, thank you very much. Appreciate the review from each of you. That's extremely helpful. And as you can imagine, we've got quite a few very interesting questions that are coming at us. And so you can all turn your cameras and your sound back on. And I'm going to pose this first question to you, Michael, because as you mentioned, and as I mentioned in introducing you, you had a really good op-ed piece in the Times this morning, and about testing. And as you can imagine, I got some questions related to that. And so there's a couple of them. One is a person who had taken a plane from Boston to the Twin Cities. Within 5 days or so, it developed a dry cough, heavy chest, high temp, very bad fatigue, and thinks that this person may well have had the COVID, not sure, but wants to know if she gets a test, an antibody test, is that test going to be, are we going to be confident enough in the results of that? She's got elderly parents, and so, she's concerned about that. And then the second question related to this is one from a friend of ours. It seems like it would make sense to do massive testing in 1 or 2 states, both the PCR test and the antibody testing. Why not do this in Minnesota? Mike?
Well, first of all, there are really 3 different aspects to this question that really come to bear here. First of all, anyone who is clinically ill with compatible symptoms should be able to be tested by PCR, by the actual looking for the virus, not the antibody. The antibody very well may not be present for 2 weeks or more after onset of symptoms, and doesn't tell you when that person is necessarily infected. Whereas if she's clinically ill, then at that point, that's when you should be tested. But the challenges we have right now are threefold. One is we just don't have enough tests. In December of this past year, when Wuhan first happened, the reagent world, including the availability of swabs, was being supplied by a supply chain and manufacturing system that was basically geared to about that of a fire hose kind of level. But when Wuhan happened and China then had a need for a substantially increased testing, that fire hose was even challenged. And then when the actual outbreak became a pandemic as we know it, and the whole world was on fire, everybody wanted to do testing. And now instead of needing a fire hose, you really needed a canal full of reagents. No one has addressed that effectively yet because we don't have those reagents. There are some areas of the country, Minnesota looks at this point to be in better shape at the current time, but even here we've had major shortages. I've co-chaired the governor's work group on testing and public health, and I can tell you we've had major problems with shortages here. So just because people want to test doesn't mean they can. I'm reminded a little bit of former Secretary of Defense's comments once: when you go to war, you don't get to go to war with what you want, you have to go with what you have. And so until we actually fix this issue with reagents, you can recommend all the testing you want, and it's not going to happen. Number 2 is the fact that we have a real problem today with what tests are on the market. The FDA reacting to CDC's inability to get a test publicly available basically opened the floodgates in its process of approval for both the PCR testing as well as the serology testing. And in the process of doing that, basically trying to get all comers to come, we've just lost oversight of the quality of these tests. We have many tests coming in from China today being sold in this country. PCR tests up to 40% false negatives, meaning that in fact they really are positive and they're not finding them. The serology is even more complicated. And so until we weed out all these bad tests, and as was described by a very senior FDA official a short time ago, crappy tests, we're in trouble in terms of just the quality. The third piece though, and this is epidemiology 101, this is what everybody on this video hopefully understands, is that screening tests as such are all about prevalence in terms of what goes on here. So if you take an antibody test right now that has a sensitivity and specificity of 95% for both, which is a very high quality test relative to what's on the market, put that into a population of 1 million people with that 5% prevalence, which is what we believe is clearly the likely level here in Minnesota right now, and see what happens. If you tested 1 million people in a 5% prevalent population with this test, that would mean 50,000 people would basically be really positive, 5%. 47,500 of them would show up as true positives. 2,500 would show up as false positives, or excuse me, as false negatives. And so you miss them. But more importantly, 47,500, an equal number to the true positives, would show up as false positives. We wouldn't have a clue what these test results really meant. One, are you really protected or not? We don't know. But more importantly, if I told a nurse or a doctor or some citizen that was counting on being protected, oh, by the way, you're positive, but you have a 1 in 2 chance it's not real. What test is that? And so people have not understood this. So when they talk about applying these tests wide scale, there are real challenges with doing that. Both one, from availability, two, from how good the tests are, and three, even if they're good tests, screening in a low prevalent population is a real major challenge. And we've not discussed any of these in a meaningful way.
Yeah. Thanks, Mike. Jeff, this is one for you, and this has to do with hotspots that are going on with meatpacking. Some questions about why are meatpacking plants hotspots, and what needs to be done to make them safe workplaces?
Yeah, we've seen, especially in the last 2 weeks, this is a phenomenon that across the country with the number of processing facilities. It's poultry, swine operations or pork plants, as well as beef operations. And we actually are seeing this throughout much of the food chain. So this is really reflecting, again, the systemic impact of this disease. And the question is why meatpacking? There's a couple things. One is just the way that we do meatpacking. So oftentimes people are shoulder to shoulder and really can't practice social distancing. So that's actually part of it. The other is the social structures that go with it. Oftentimes these are migrant workers, immigrant workers. They're housed together. There might be multiple families living in a small amount of space. So again, the idea of being able to social distance is another challenge. The other is basically access to healthcare for many of these vulnerable populations. They don't have access, or they may have concerns about their immigration status where they don't want to draw attention to themselves. The other aspect of this is that language. Oftentimes, many of the folks that are working in these plants actually speak multiple languages. Just in the Smithfield plant alone, there are 20 different languages that are spoken there. And so how do you educate? What's the best way to reach those individuals? So those are all part of probably some of the reasons why we're seeing some of this transmission, especially in a sense, in a congregant setting like we have with the long-term care facilities. But again, congregant setting where we're bringing lots of people together.
And this is a question, Tim, for you. And this has to do, there's a number of questions related to this, but what they boil down to is you're doing a lot working with healthcare systems in this kind of learning healthcare system framework. What do you see healthcare systems really needing to learn from this situation? And how is that going to influence the way they change in, say, a post-COVID world? We certainly don't want to see healthcare systems overwhelmed like this in the future. What do we do about that?
Yeah, that's a good question. What can we learn from this? And I think, the standard, understanding supply chains, how to understand the modeling, and how that the outbreaks are going to impact resource allocation, and how to line those things up. But I want to focus on a few things that actually we've been observing in this pandemic. I think systems really need to focus more on value. One of the things that the COVID outbreak has done, it impacted something that healthcare systems and payers have been trying to do for decades, is decrease the amount of low value care that's incredibly expensive but confers very little clinical value. Just because of the social distancing and the deferral of elective surgeries and non-essential procedures. Some of these not low value care, like imaging, injections, or surgery for low back pain, or catheterization or stents for chest pain, or lab tests for low risk patients, or prostate cancer screening, routine head CTs for dizziness. These things that really haven't been able to be done because people, non-COVID cases cannot seek care, but those are low value procedures that have really driven healthcare costs really high, and about 55% of the patients don't get the care that they need, or unnecessary care. So take advantage of this opportunity to start changing the payment structure to incent high value care for things like physical therapy for low back pain as opposed to something interventional, or medication for chest pain. Things that really prepare us to, again, anticipate the next one where there's social distancing and lack of access, but also really chime with what the evidence that suggests would be care that confers the best benefits. So really shifting the perspective of fee for service to fee per patient, and really taking this opportunity to change the payment structure so that once the surge is done and healthcare industry is open up for business, that it doesn't go back to the standard fee for service. I think they need to embrace telemedicine. This is toothpaste that can't be put back in the tube. I think that it's been moving there slowly. I think there's a reticence on the part of providers and patients to engage in that because there's a preference for laying on hands medicine. But I think this is shown, and initial evidence suggests that both patients and providers like this. It's increased access, and it's conferred value in terms of scheduling and not having to wait in the waiting rooms. And I think that another thing that this healthcare system need to do, and I think we have movement there, is move to community-centered care. We've done a nice job moving from physician-centered care to patient-centered care, but I think an increased move to community-centered care, understanding that really authentically engage in population healthcare delivery. Knowing, and everybody's seen this graphic, 10 to 15% of health is contributed by the healthcare system, and the rest are social determinants. Understanding that the healthcare system is part of an ecosystem, and that stronger ties with public health are needed to really confer health benefits to the population. And I think that also means that we have to start moving upstream in the training of the providers and the types of providers we hire. I think last fall there was a op-ed from the former dean of the medical school at Penn that said, we need to move away from all these social justice issues in medical school and get back to the basics, technical skills. And I think that's the wrong direction. There's a lot of backlash saying that, clinicians, because of their standing in society and their position in the middle of things like this, really need to understand health policy, health economics, pandemics and epidemics, health law, to really be in a position to understand and facilitate those connections with the community and the assets that exist. So I think those are to position ourselves better for the next one, outside of just the understanding the supply chain issues and the modeling and resource allocation. Those three things, I think, if we can take away from this as benefits, the value, focus on value, telemedicine, and a stronger and faster movement toward community-centered care, I think would be beneficial.
All right. Well, Marizen, a couple questions come in, but this one I think is one that I'm just bringing a few of them together. Um, we've read that people that are working in the domestic violence field feel that it is increasing during this pandemic. And yet there are hotlines and other resources are receiving fewer calls for help as far as we know. So could you talk about these aspects of the pandemic that put people at higher risk for domestic violence? We're seeing, alcohol increase and other things I assume associated with that.
Absolutely. Thanks, John. So what we know about domestic violence is that abusers tend to isolate their victims. It's typically a controlling behavior. And so when we've put in place these social physical distancing strategies, it's likely that these controlling behaviors are increased. At the same time, when you think about the resources that would be available, the community supports that would be available to families, they're limited. The churches, the schools, the libraries, these are places where many targets of domestic violence would seek supports. So we've sort of created this environment because we want to engage in that social physical distancing to prevent infection and spread. At the same time, there is the secondary impact in which we're reducing the social supports, the access to resources, and creating a much more potentially dangerous environment for families that are at risk for domestic abuse. So what's kind of interesting is I think there's this sense that some of the targets of violence, because they're in a much more controlling situation at home, they're unable to reach out and make those calls to hotlines because it puts them at risk. So that's one thing on the one hand. So we know we're missing an important segment of the population. At the same time, there actually have been reports, John, that calls to domestic hotlines have increased about 20 to 30%. So in the state of Minnesota, we've seen that. We've seen them in France and in Spain and in Italy, and in Brazil. So there is sort of this interesting balance, but yet we are still missing, potentially the most dangerous environments. At the same time, and I think I mentioned this, that law enforcement calls for domestic violence have increased by 25%. So there is, we are challenged right now in trying to find the ways that we can support individuals in an environment of social distancing. And so, I think there are advocates that are out there that are really trying to push forward to find the ways that we can support families who are at risk. And I do believe that, it is about reaching out to friends and schools. These environments are ways in which we can increase that connectedness, because ultimately that's a way that people in help who are in need of help can find that help.
Yeah, very good. Mike, this is there's a set of questions that have to do with supply chains. And it seems that part of the preparedness problem we've experienced in this country is that over the years, we basically sent a lot of our manufacturing capacity to other countries. N95 masks are primarily manufactured in China. There are machines, ventilators, and others that are manufactured elsewhere. In the post-COVID world, if we're going to be able to have our own manufacturing, is that having our own manufacturing capabilities more evenly distributed around the world rather than locked up in one country? Would you see that as really pretty critical to a post-COVID world so we don't get caught flat-footed in this again?
Well, thank you. Clearly, the whole supply chain concept is going to be rethought about in terms of what this pandemic is showing us. But let me just back up a second and just say that in 2003, when SARS occurred, literally shutting down large parts of China, people really didn't worry about supply chains in the sense of what that shutdown in China might look like, because we had so little of critical products coming from China at that time. Where we're at today, and what I mentioned in my introduction about how we're actually more vulnerable today, that's changed substantially. But I do want to clarify a couple of things. Actually, there are some things in North America that we actually do pretty well. For example, N95 respirators actually are made here in large volume. And there are also those in China that are made, but they primarily have stayed in China, with the exception of some coming into the United States in recent years, cheaper products coming in. So when this whole issue emerged in Wuhan, actually companies like 3M actually went forward and upped their production substantially, even in January, knowing that in fact here in the United States that we would need these. So that's key. But let me just give you one example of where things have gotten really tough. Our group has been funded by the Walton Family Foundation for the last year and a half to really look on drug shortages. We had identified for some time the issue of acute critical drugs, those drugs you need within hours if people die or are seriously harmed by the absence of those drugs. What's on the crash cart, what's in the emergency room, what's in intensive care, what's on the ambulance brake. And we identified through a process of bringing groups of experts together in medical care, 156 such drugs. 100% were generic. Almost all were made outside the United States. And in addition, on any one given day before Wuhan happened, 62 to 63 were already in some shortage status phenomena where just the normal market forces did not keep enough drugs coming into the United States. When this particular pandemic hit, it began to challenge us substantially, not just because of China, but because other countries that did make these drugs or in collaboration with China then began to put barriers on the export of the drugs, wanting to keep them for their own country, India being the most notable. Ironically, the one area in the world besides China and India that made antibiotics was the Lombardy region of Italy, which was hit heavily by the Milan-based outbreak. So we've run into challenges there. And so I think that what we've identified is this incredible vulnerability that we have. And I might add our own Defense Department is procuring drugs in that same supply chain world that everybody else is. There's no strategic national stockpile for these drugs. And so I think we really have to take a very, very careful look at this to see. We are very concerned, for example, with drugs, paralytic drugs that are needed to intubate someone, keep them so that they can, in fact, have a ventilator. Right now are in very short supply. And we worry we may run out of, in a future wave, paralytic drugs before we run out of ventilators. Either way, we're in trouble. So I think that this is the kind of work that really needs to be really looked at carefully. What are those critical products, services that if we don't have, we're in deep trouble? Which of those we'd like to have? If your car doesn't have brakes, that's not good, but you don't have to buy a new car necessarily. But if your family member needs a drug that is necessarily limited and there's no other alternative sources, that's huge. So I think you're right. Well, I do sense we will go back and we look at this. I can tell you we're having discussions with senior leadership in various aspects of this administration right now about the challenge that they see because they understand that this is a huge issue.
Jeff, this is for you. This is coming from one of our listeners. It says, can you speak to what is being done to address the supply chain issue between farmers and currently operating settings such as food banks in respect to reports of farmers dumping milk, et cetera, because schools and restaurants aren't buying their products? I'm concerned about the uninformed yet viral narrative that farmers are being wasteful and how this demonizes an already misunderstood and underappreciated industry, and how this ultimately contributes to poorer mental health outcomes and suicide risk among farmers.
I really appreciate that question. I mean, one of the things about, public health is that we are concerned about the communities and we are concerned about the public. And, there is a fair amount of inequities oftentimes that we think about. And actually, some sectors of our community are stigmatized, and farmers unfortunately have been lately, and part of it is understanding that supply chain that Mike just really elucidated on. We've actually streamlined our supply chain so much so that on a given day, a meat packer says, okay, I expect your truck to come into my processing facility and you are to deliver on this day. This is the only day that you can. If all of a sudden the workers don't come and those trucks start to pile up, there's no place for those pigs to go. And there's nothing that probably makes a farmer sadder is looking at animals that he's he or she has invested, 6 months in, to then not have an income and then basically to waste. So that unfortunately is a tragic scenario that actually is being played out in many respects throughout the country right now. And it's not just animals, but actually there are fields that are being plowed under because there is no one to pick those things. So that shows you how tight our supply system is, and that it basically, if we don't have workers, then we can't pick those products, and they don't make it. And so a lot of people think, well, gosh, the farmers are wasting. And I think the caller really hit the nail on the head on a number of different issues, and they're not. This is why we need to look at strategies of how that we come alongside the producer, come alongside the farmer, and try to come up with some strategies to help them in this, and then also to make sure that we've got a workforce that's healthy, that feels comfortable coming back to work as well. And so those are some of the challenges that are before us right now.
Thanks, Jeff. Tim, a number of questions again related to healthcare systems and the way that this disease might well help us to evolve. You talked a little bit earlier about the conjunction, if you will, between healthcare systems and that they may move to focus more on population health management. Could you talk a little bit more about that? I think it's from a standpoint of, so what does the structure of healthcare look like? Are we really talking about public health and healthcare sharing more, getting closer together? How would you look at that as perhaps something that we might want to encourage in the healthcare and public health systems going forward?
Yeah, I think we've seen some movement in that space with healthcare systems and public health. So, there's this movement of accountable health communities, whereby there's an increasing understanding of the whole spectrum of contributors to a person's health. As a sociologist, I've known for 30 years that the biggest predictor of your health is where you live. And so that's finally catching up to the healthcare delivery system. So the idea there is that, and there are a number of different pilots and programs that are trying to connect the healthcare delivery system with assets that exist within the community. So, if there's a housing challenge, how to ascertain that, and how to maybe find housing for the person, for the patient, and either through Hennepin Healthcare had a tiny house program, Intermountain Health is buying apartments, United Health, Kaiser, they're purchasing housing to have that stability before any sort of clinical intervention can be pursued. I think the problem there is, from my standpoint, is, and it's nothing against the healthcare delivery system, but the healthcare delivery system is trying to find a fix to this. It's trying to recreate some of these connections with assets around food insecurity and housing insecurity and challenges around coverage. But I think a lot of those assets exist within the communities already. It's just forging those connections. And part of the problem is that there's pockets of pilot projects going on around the country, but there's no payment model. And so once they don't show any sort of financial benefit, they go away oftentimes. So I think that there has to be a concerted effort to try to look at the best practices, look at health-related social factors that need to be embedded within the larger health ecosystem, of which the healthcare system is one component. So part of the problem is dissemination of best practices, orchestrating things at a more macro scale, and coming up with payment policies that sustain these strong collaborations, which the demonstration projects that CMMI, the Center for Medicare and Medicaid Innovation Program, funded accountable health communities where they connected people with, if they needed food. You can yell at someone with diabetes for not eating more fruits and vegetables, but if they live in a food desert, it makes no sense. So there are a lot of positive results coming from these innovation pilot programs that show that there's some signal there, but it's just sustaining those through a larger payment infrastructure and a more macro view of how we can do this across the system rather than just in catchment areas.
You know, and related to this, Marizen, there's a question from one of our listeners. It has to do with families and children that have been traumatized already, and there are likely additional traumas yet to come given the economic stresses, housing displacement, and so on. So what would you say are the top few policy initiatives that could help cushion the effects of these traumas, or maybe even help us prepare for whatever might come along in the future?
John, I think Marizen got kicked out because of her internet problems. So.
Oh, okay.
Yep.
Sorry to hear that. Okay. Well, in that case, I'm going to run to another question here, and I'm going to start with Michael on this one. So one of the big issues, I guess, has to do with the underlying health conditions. They seem to be a major factor in the ability to survive this disease. Is there any movement to test specific vulnerable populations and those rather than those those with diagnosed conditions?
Yeah, well, first of all, the observation is correct that the comorbidities that we see in individuals who are infected with the COVID-19 virus are clearly very important indicators of how a patient might do in terms of the seriousness of the disease and whether they might actually survive. So that we do want to understand that. They're still being worked out, but clearly cardiovascular disease, renal disease, certain cancers have now been associated with this. And one of the factors in the United States that is playing a very important role is obesity. Now that surely is a potential confounding marker for diabetes and a number of other things, but that under age 50 in particular, very strong risk factor for those who have had severe disease and have actually died. So in terms of trying to understand this as we move forward, these are the people that the advice we give them about trying to avoid infection is even more important in terms of being exposed, because if they do get exposed, their risk goes up precipitously for having a bad outcome. So, and then one of the things I want to emphasize is that, grant you, a number of the deaths have been in people over age 75 to 80, and that there's still a death. But one of the things that's very sobering fact is yet in most of the healthcare delivery areas of the United States, only about 20% of the people who ever get put on a vent survive. 80% do not. And we're still trying to understand that, because there surely appears to be some very different issues now about what we think is actually happening from a pulmonary standpoint. There are issues about certain blood disorders, stroke phenomena, inflammation in the heart. I can go through a laundry list that this disease is teaching us we know very little about. So, but to summarize it, if you have one of these underlying health factors, it's all the more reason why you do not want to get infected with this virus.
Yeah, and it seems that almost every day that goes by, we're learning more about the symptoms and presentations of this disease. So it's clear we don't fully understand it yet.
That's true.
So Marizen, I understand that you're back online, and one of the questions that came from one of our listeners had to do with families and children that have been traumatized already, many yet to come given economic stresses, housing displacement. What would you judge are some of the most important policy initiatives that could help cushion the effects of those traumas?
It's a great question, John, and I apologize for my connectivity issues. I'm now on my iPhone, so, but it's a really excellent question. You know, I'm thinking from a disaster preparedness standpoint.
Mm-hmm.
When we think about disasters and how we respond and respond to trauma in general, there's a fundamental issue is that we get them economic stability, we get them food, we get them housing, we get them medical care. So these issues are really critical, especially for, I'd say, our most vulnerable populations, those who are in low socioeconomic status with reduced financial access to resources. So all of these factors are critical from a policy standpoint, that we really do need to think about addressing those populations that are really at greatest need.
Okay, thanks for that. The other issues that are being raised are vulnerable populations in a variety of settings, people with disabilities, and in addition to of course, to different minority groups. And one area that's been raised as well has to do with American Indian populations in the U.S., many of whom live on reservations. I believe we have 12 reservations in the state of Minnesota, and that there are contacts that are going on with tribal representatives and communities very much right now, and the health department involved in that as well, looking at the needs and the issues that they have. But in terms of a post-COVID world, it seems to me that disadvantaged people, disadvantaged in a whole variety of ways, always seem to take the brunt of these sorts of events. And so from the standpoint of the planning and preparedness piece, it would seem to me that there's a number of policy issues that we would really need to build in to public policy to assure that that is less likely to happen in the future.
And John, I just wanted to add to that, a really important piece of this is really taking a community-based approach in which we are working with partners from these communities to identify the best strategies to reach populations that are culturally responsive, that address language. Even when we think about the ways in which information is being spread about strategies and guidelines for social physical distancing, for essential workers. There are many populations there whose first language isn't English, and it is not necessarily written as well. So we've learned that a lot from working with various populations. So I'd say this is a time that we can really think very carefully and strategically about the partners and bringing them to the table so that their voices can be heard.
Thank you for that. And this is something, a question I think for all of you. And this is obviously from a friend of ours. So in the world of public health, as many of us know with a little gray hair, we are constantly dealing with the angst between being reactive, like we are in right now, vis-a-vis proactive, which we constantly try to promote. So no matter what happens with COVID, do you believe we will still be going forward with this tenuous balance, or will this be the wake-up call, all in caps? That is the $64 trillion question. I'd be curious how each of you feels about that.
Maybe if I'll start, just because I've given, obviously, as our team has, a lot of thought to this over many, many decades. And you're absolutely right that we tend to be reactive. And unfortunately, I think part of that is the issue of creative imagination. I mean, if I've heard it once, I've heard it 20 times, that how could we ever have imagined this happening? And yet, those of us who have been involved with this have written about exactly what's happening years ago and said this is what we need to do to deal with it. And so when you don't believe you're vulnerable, and you don't believe that, in this case, public health and i.e. infectious diseases can do this, then you don't need to act. On the other hand, you can also say, well, this is going to be so damn bad, there's nothing we can do about it anyway, so let's just go to bed and take a bottle with this and wake up when it's over with, okay? And that's not true either. And so I actually would like to challenge the questioner, because I think it's a great question, about the fact that you can be proactive within a reactive moment. And so one of the things that we've been trying to do is actually anticipate what's going to happen. I do believe that we're going to see a substantial increase in the number of deaths and cases over the course of the next 12 to 20 months. And so there's much we can do right now to get us better prepared. A good example, I mentioned on our drug work that we're doing, we actually are working right now with the governor's staff, the Commissioner of Health, the Health Department, and the Emergency Operations Center, and a group of pharmacists from around the state to set up a very unique surveillance system for drug shortages well in advance of when they might occur, meaning at the wholesale level, anticipate when we might have 2 to 3 weeks notice that this is going to occur, rather than waiting until the morning of and finding out, oh my, that didn't arrive today, which is what happens typically. And so we're trying to gain some time to give us an opportunity to be more proactive, to find substitutions if necessary, or to basically, in a sense, find some other way to do what you were trying to do with that drug. And so I think that public health can still do both. And I think that comes from our roots at the public health agencies. I mean, all those who are on this video who've worked in public health agencies understand it. Jeff and I understand it very well. We did many things related to outbreak investigations, where on one hand, we were being reactive. The other hand, we were proactive, trying to make something better than it was. So I think this is true. I don't know what's going to change, other than when people see moments like this. My fear is that one or two things will happen. When we get over this one, which we will, people will say, I don't want to hear about this again, go away. Or people will say, this is a crisis we cannot lose the opportunity to learn from. This is our black box moment. You know, just because it's tough, don't go rescue the black box and figure out why it went down. You know, what can we learn about it? And that's one of the things we're promoting right now, is that very piece, to make sure that that infrastructure is in place. So one, we're capturing the information about what's happening right now. And number two is, and how can we use that when one day, when this all is over, to say, we can't let this happen again. This is what we need to do to make sure that doesn't happen.
Mm-hmm. Mm-hmm. Others want to weigh in on that? Jeff, Tim, Marizen?
I'll just say something briefly, and then I'll defer to the sociologist in the group, Tim, to give me the right answer. Mike really pointed it out very well. And the thing that, as I think about that question, I think about my own personal response, and it really is a human nature, this reactiveness. And I think Mike's admonition, that we have an opportunity to be proactive in this. And I look at the success of public health over, the generations that we've had it. The mere fact of immunizations and the fact that we've eliminated smallpox, we've had a number of control efforts to really reduce guinea worm. There are huge successes that, as a public health, that we can really claim. And I think that we need to have that hopeful vision. One, be reactive, be realistic, and it's very human nature. At the same time, too, hopefully we can continue to learn and that we don't forget. I remember bioterrorism preparedness and influenza preparedness 20 years ago, as Mike pointed out. And we, in some respects, we were better prepared during that time because we were thinking about these things. And I think that we go in because of our human nature and forget and think, oh, this isn't going to happen to us. But I'll defer to the sociologist of the group to correct me.
I think that's no one asks a sociologist to correct anything, but thank you for asking. I think that you're spot on. There's just one thing to add, and I shared this article that came out yesterday with John this morning. It's called Putting a Stake in the Heart of the Public Health ER Complex by Thomas Frieden. Talking about how the passivity of our discipline needs to end. This is our moment, and we need to hold on to this in the public narrative and demand that their infrastructure changes. Make the per capita spending on public health is 40 times less than on healthcare. 11,000 per capita for healthcare versus about 260 for us. And investing in the infrastructure that's been decimated over the last 10, 20 years. And I think the point is that we demur somewhat. We stand up and we do it. And the name of our documentary, The Invisible Guardians. We can't be that anymore. And I think that we have to be in a position to both be ambidextrous, proactive and reactive, but at the fore. And I think that seminars like this, Mike showing up all over the news, that needs to be continued, to say that the most effective tools that we have right now are public health tools. and that's not by accident. But we have a tendency to cede that space to the healthcare system. You know, like when there's a downward canting in the cancer rates, you know, the interventionists and immunotherapy was claimed credit for the downward canting when it was smoking and all these other things. We just have to kind of push back on that narrative and claim that territory, and not cede it to others who are players, but probably not as big a little more bit part relative to what public health is.
Okay, Marizen, you want to weigh in?
Yes, thanks. These have all been very thoughtful responses. I think about two things. Number one is I am sure glad that people, our general public, know now what an epidemiologist is. So I'm very, very happy to be an epidemiologist, and that folks know that I'm not studying the epidermis, which is often an error that's
You're not
that
a
I have to
skin
correct.
doctor.
A skin doctor, exactly.
Right.
So this is an exciting time that the awareness of public health and the importance of the role of public health science is being put forward, especially in this time, this age and time. Second is, and I'm glad that Jeff mentioned this about bioterrorism preparedness. My training also includes disaster preparedness planning. And the cycle of preparedness is pre-disaster, during the disaster, and after disaster. And it is a cycle. So when we think about being proactive and reactive, we need to think about that cycle of preparedness and how are we going to be prepared for the next types of events that are going to strike. And it is an all hazards approach. If you look at FEMA and other guidelines, I mean, it's Homeland Security that's also right in the front of all of this, and that we can partner in the area of disaster planning to address pandemics, to address climate change, to address other weather-related events that might strike our communities, and use similar approaches, and not forget that there are many types of events that can overwhelm a community.
Thanks, Marizen. So we are just about at the end of our time here for this webinar, and we have all kinds of questions that we're not going to have time to answer, but I'm going to pass those questions on. I suspect that you may be able to get some email type answers. We'll see what we're able to do as far as answering those. But in the last 5 minutes that we have, I want to ask each of our panelists to answer one last question, and to try to do this in fewer than 30 seconds. So here we go, lightning round. What are the one or two top things that US leaders need to do now to improve this situation across the country? One or two top things US leaders need to do now to improve this situation across the country.
I'll go. So it's dovetailing off what I said before, invest in public health. I mean, there's a proposal put forward yesterday by Andy Slavitt, who just happened to be our keynote at our 75th anniversary gala. Former head of the CMS, with Scott Gottlieb, former chief of the Food and Drug Administration under Trump, put forth a proposal to fund training, tracing, and isolation. There's a $46 million proposal. Remember when he spoke at a keynote, he offered, we need to invest $100 billion into, they say 46 million, 46 billion, into public health, and we all laughed. That seemed laughable at the time, but that's kind of like couch change now. So he's there, those two, it's bipartisan sign up by a number of different luminaries. 12 billion to expand the content tracing task force, hiring up to 180,000 contact tracers. 4.5 billion to use vacant hotels where the infected can self-isolate, and $30 billion to offer 18 months of income support, kind of like a per diem for while you're on a jury duty and the like. And those would be distributed as block grants to the state. So more investment like that to gird the infrastructure in the short term and in the longer term.
All right. Michael.
Okay, well, I would just add two pieces. I think number one is we've got to be realistic about what we can do and how we can do it and what will make a difference. I see a lot of spaghetti getting thrown at walls right now that I'm not sure really helps the interior decoration of one's house. And it's often being made by people who have little experience in the area of public health interventions, what works and doesn't work. So we need to have more of that. I think the loss of CDC as a major presence in this pandemic has been nothing short of itself as a disaster. They have not been front and center in a way that I think is really important. The second thing is, we're just beginning to get going on this thing. I say this with as much sincerity and honesty as we've got a lot of hell ahead of us. And I don't think people get that yet. We're in this opening stages. And if I could ask for anything, I'd ask for a FDR-like leadership that could have fireside chats with us over the days ahead, over the months ahead. Not answers. There won't be answers in some cases, but there will be a commitment to telling the truth and to doing whatever they can to find answers when they don't have it. And I think that's going to be incredibly important as we deal with the biologic and the psychological issues associated with this pandemic.
Thanks, Mike. Marizen.
To add to this, I'd like this message about investing in public health. And absolutely, as an injury and violence prevention researcher, it's probably one of the most under-recognized public health problems that impact our communities. We've already expressed here in the seminar how trauma is really seriously impacting individuals that will last beyond this pandemic and will continue to impact communities throughout our world. So if I'd say, I've looked on and tried to study how much investment has our government, our leadership put into domestic violence prevention. It's actually very little has been added for COVID. And when I think about programs to support domestic violence, sexual assault, dating violence, stalking, there's zero funding that's being implemented and being pumped into these programs that we are going to see and continue to see those numbers rise well after the pandemic goes. So I'd say violence prevention, injury prevention efforts, and also to find evidence-based approaches. We are scientists first and foremost, and we need to put the science that works. And I know that some of this is real time because we have to be creative and we've got to do some things immediately to respond to needs. But if we can really in parallel conduct the science so that we know which paths to take. And I know, Mike is out there, really putting forth the importance of science as all these new testing strategies are being implemented. That'll be a critical, important role for public health, I think, for as long as we're around.
Very good. Thank you so much. I want to thank everybody for joining us. By the way, one of our listeners described this discussion as compassionate, relational, and science-based. And so you can take that home and share it with family and friends. I will say this, and we'll close out. It seems to me public health is everyone's responsibility. It's not only a government issue, a public system issue, a private system issue. It is everybody's responsibility in some way, shape, or form, because public health is about all of us. It's about medicine, it's about nursing, it's about pharmacy, it's about veterinary medicine, it's about dentistry, it's about all the health sciences and engineering and sociology and all of those other things that we've been talking about. And it seems to me that in a post-COVID world, I would definitely look forward to the collaborations that could come up with a different vision than the one that got us to this point. So thank you all for joining us. And be sure to stay in touch with our school at sph.umn.edu. Thank you for being with us today. Stay safe, stay well, and keep up your spirits.